All right. Well, thanks for having me, this is going to be fun. I'll tell you what, we're not going to get into the weeds about the ethics of end-of-life care. My presentation is going to be about one method that we use at Ohio State to teach these very challenging subjects. So this is really, truly an educational grand rounds. I'm going to talk a little bit about the background of the course, why we did it the way we did it, how you can successfully combine using simulated patients or patient actors with team-based learning, both of which are evidence-based medical education processes. Oops, so let's go forward here. So my name is Ashley Fernandes, and I know we have a Leslie here. I thought that was kind of interesting. I'm not a Hispanic woman, as you can tell. And if you Ashley Fernandes is a Portuguese last name. I'm not Portuguese. There was a part of India that was colonized by the Portuguese in the 1500s. The people that converted to Roman Catholicism took the only Catholic names they knew, which were Portuguese last names. And so that's how I got Fernandes. And actually, Ashley, my parents were Gone with the Wind fans. And I don't even think the movie had come to India until the 50s. So my dad had read the book and liked the movies, and so that's how I ended up with the Ashley part. But you'll be surprised, in the Indian Goan community, which is where there's a lot of Ashley Fernandeses, which is kind of unusual, a lot. And there's another one that I thought you should be aware of, is also of Indian ancestry, also studied at Johns Hopkins. One of them was convicted of murdering his girlfriend, and the other one has a wife who would sometimes like to kill him. One is pretty dangerous, the other is fairly harmless, and just so there's no confusion, these are the two people we're talking about. Now, I did want to point this out that I've been making this joke all over the country. And so I had to actually look up after the fact. I'm like, what if this guy gets out of prison? And then he realizes there's this other Ashley Fernandes who's been making fun of him, and it turns out he has life in prison without parole. So I am safe. So I have no disclosures whatsoever to make. I am a pediatrician in academics who teaches ethics and is involved in medical education, so I definitely have no financial conflicts of interest to report. In fact, I have no finances to report almost whatsoever. So there we are. All right, I'm going to have Bree hand out some handouts if you guys are into handouts, so we can just go through, if you want to, some of the objectives. I'm going to talk about some of the challenges to teaching ethics and advanced communication, describe some of the benefits of using team-based learning and simulated patients and how we might be able to combine them, and then describe our approach that we used at The Ohio State University and some of the limitations and advantages of using this method. So I want to start with some of the educational challenges, and the great thing about this is since you guys are all interested in med ed, you know that this is the case, and it's probably, my guess is, universal. If you look at the data, this is a universal problem. So even though we have over 1 billion, if you include the ED outpatient visits or the urgent care outpatient visits, there are over 1 billion outpatient visits per year in the United States. We have about 36.5 million inpatient stays. Average length of stay is 4.5 days. Average cost is over $10,000 per stay. But medical education is, at least at The Ohio State University, and I'm sure a lot of other places, is decisively skewed toward the inpatient model. So a lot of places, I mean, in your third and fourth year, what do medical students actually care about? They care about their inpatient rotations, even though most of them will be doing most of their practice outside of the inpatient setting. I teach primarily in the fourth year. I teach through all 4 years at our school, but I teach primarily in the fourth year, and what we've noticed, particularly since I went to medical school, is we've noticed this increasing emphasis that fourth year is meant for one thing and one thing only, and that is to get residency interviews and to match. So the fourth year, this idea that the fourth year becomes match day. That's it. And after that, you don't care about it, and anything else that interferes with the process of you getting the match you want is a problem. So when you think about this in the context of trying to teach things like bioethics, or trying to teach things like empathy, advanced communication, any humanistic skills, these can become a barrier to students whose perception is, I'm here in my fourth year to do one thing and one thing only, and that's match, and you're annoying me with this extracurricular stuff. But in fact, we know that physician communication, things like teaching advanced communication, becomes extremely important. This is a study which you guys, some of you have probably already read, that talks about how in these cases, 19%, in this particular study, reports that 19% of patients would be more adherent with proper physician communication. So teaching advanced communication skills is not just an issue of, oh, well, this is the ethical, humanistic thing to do, but because it actually affects patient outcomes, it becomes very important. Now, there's been this conflict between the undergraduate medical education. You guys have probably seen this ridiculous meme. But between the undergraduate medical education world and the GME world, there are some subjects that nobody wants to touch. Oh, we'll handle it later. You'll learn that in residency. Okay? Some of the topics that we have to teach have to be done in both worlds. But because of this battle between the UME and the GME about where to teach it, it becomes challenging. No one really wants, not many people want to teach ethics formally, for example, or want to teach something like advanced communication, health literacy, some of the behavioral science topics that are so important in actual clinical practice. So what about professionalism and other cultural challenges that we find medical education situated within? This is a headline from the Columbus Dispatch, and this is from 2016. But there are two headlines here that are above the fold, as we used to say in the days when people actually read newspapers. My students today don't understand that expression at all, so I have to explain it to them. He said there's these things called newspapers, and they're actually made out of paper, and they have this expression called above the fold. So here are two above the fold stories. The first one is hospital charity care shrinks, and this is about how in Columbus, a lot of the charitable care for the indigent and the underserved is being eliminated in favor of freestanding emergency rooms. Okay. Now, what this particular story talks about a system called Mount Carmel, which had as part of its sort of Catholic mission for healthcare as serving the poor. And they had a main hospital, which was downtown, which had a lot of primary care clinics. A lot of the underserved and indigent populations used these primary care clinics. They decided they were going to shut that down, transform it into in a freestanding emergency room, and move their main hospital out to the eastern suburbs. So the poor people can't get there. They lose all that care, but they make a lot of money off the freestanding ER, which helps the hospital system as a whole. This other one is about patients ridiculed in photos. Now, thank God these were not medical students. But what this story talks about is how nursing, it's either nurses or nurses' aid students had patients with dementia, and they took Abu Ghraib-like vulgar, lewd photos with these patients with severe dementia. They lifted up their gowns and made gestures and that kind of thing, and they were caught. I point this out to the students to suggest that if something like this happens, even though it's not your profession, they're not med students, but if you're counseling a patient about putting their mother or a grandmother in assisted living and they read a headline like this, they're not going to listen to you. They're going to be a lot more skeptical about whether they should do that, whether it's safe to do that. And so professionalism issues that happen at large or that happen within the culture are then going to affect the way we practice medicine. By the way, my students also, many of them, do not know what Abu Ghraib is. They don't understand that reference because some of them were actually born after. I mean, it's so crazy, but some of them were born afterwards. Or they weren't taught it. And then there's this, that when you get, particularly after the third year, but how do you get students to actually care and want them to see what their role is as a physician, as a caring role? And this I find challenging if they've already gone through third year and they find themselves somewhat jaded by the time they finish third year. It's like you've got 20 or 30 more years of a career in medicine. So trying to get medical students to care is an educational challenge when you're trying to teach the topics in particular that I teach. This is a Twitter feed photo that went viral nationwide, and it's from, as you guys know, Ohio is one of the sort of the crossroads of the opioid epidemic. And in this particular photo, I show this to the students, you can see these two adults in the front, and you see this little child in the back. So I asked the students, well, what's your first reaction when you see this? And they will say, oh, well, we're really angry. You know, we're disgusted that here's this little child and these two people are in the front. But this is the point of what we're trying to get across to them, is that if you are a physician, that's true. You do a lot of, you know, your first reaction is your natural reaction. But to be a compassionate, humanistic physician means that there are things that you do that are going to be unnatural, which is you have to put aside the fact that you're disgusted with the adults in this photo, and your obligation is to convey generosity, care, humanistic care, even for the people in the front. So it's the key thing here, trying to get the students to realize that part of the sort of nobility of medicine is that you don't get to decide that you're not going to devote your technical skill, your intellectual ability. You don't get to decide that because of the way these people behave. And then I try to point out to them that this is a challenge. This is where some of the burnout or kind of the suffering of the provider in medicine comes from, is you're asked to do unnatural things that don't come to mind for most people, and still to devote your best to these people regardless of what they've done. So getting them to care, I think in part, it's not just talking about it, it has to be experiential, but it has to be intentional. It has to be something that you kind of point out to them. This is a shocking photo, yes. It's even more shocking, by the way, because at first blush, you think that these are the parents of the child. And actually, these are not the parents either. These are the grandparents, or this is the grandmother and the grandmother's boyfriend. So that tells another story in and of itself, which is that this child is in the care of a grandmother. So what happened to the mom? Or what happened to the dad in this situation? I mean, it's a very sad photo on a number of different levels, but you have to be able to convey to the student, hey, what we're teaching here is going to matter to you in practice. This is going to be your ER visit, one of these people. And what are you going to do when they come in? How are you going to treat them? It's not just this little boy. It's also the people in the back seat. Now, because of this, these sort of pressures that I've kind of laid out, these barriers to teaching some of these subjects in medical education, some of these subjects become orphans. And I call these sort of the orphans of medical education. At my institution, nobody wants to touch some of these. They don't want to teach it, right? So we've seen a decrease in the amount of time for ambulatory medicine, in chronic care medicine, in teaching communication skills, things like healthcare access, ethics, professionalism, social justice, interprofessional education. These are things which will go by the wayside in favor of inpatient care, or if it's driven solely by what the students perceive to be important, it's going to be, how can I match? How can I get the best residency? So all of that is all about the context of where we developed this intervention that I'm now going to describe. LSI stands for Lead, Serve, and Inspire. That's what we call our curriculum at Ohio State. And I'm not sure of the structure of the medical school here, but instead of, you had a recent revision of the curriculum, right? So did you guys go to like sort of 3 parts, or did you shorten years 1 and 2? Or is it still preclinical and? Okay, okay. So yeah, so we sort of shortened our preclinical. We don't have that divide, 2 years preclinical, 2 years clinical anymore. We have 3 parts, and part 1 is essentially what used to be year 1 and year 2, but condensed into 18 months. And then you've got part 2, which is your year 3, and that's pretty much stayed very similar to the old model. Part 3 is where I teach this course and this intervention, and that lasts about 13 months, and that's called Advanced Clinical Management. And then they have other longitudinal projects. So I wanted to show you that the particular course module that I'm going to describe is located here in the fourth year, so in the 3rd part of our curriculum. And the course that I teach is called Advanced Management in Relationship-Centered Care. And that is essentially a 2-block course, although we have about 1/3 of our students who do this course longitudinally. That is, they can fulfill the requirements over 10 months. And it is required of all medical students. So they have 2 required, like sort of 2-block courses. One is their sub-I in emergency medicine, and then the other one is my course, which we teach them outpatient and chronic care medicine. Now, the way I designed the course is I reduced the number of clinical hours that students had to be in clinic on purpose. They act like sub-Is, but they only have to do half the number of required clinical hours. And this was so that we had the curricular space in order to be able to teach things outside the clinic. Because I have a PhD in philosophy, so I'm a firm believer that you can actually learn things outside that are relevant to medicine outside of the clinic. And so we give them some time to, for example, go to an NA meeting, go to a go with a home health nurse or social worker and go into the home of patients where they can actually see how home health care is delivered and those kinds of things. Now, luckily for me, our course is worth 35% of their final M4 grade, and so if you don't do well, you can't graduate with honors. It'll affect your overall graduation. So I think this is important when you teach, because you want, if everything was optional, students just wouldn't do it. And so what this shows is there's a heavy investment from leadership from the top down that is beneficial to us. The sort of stakeholders that we have on board believe that this is important and believe that these subjects are important, and that's extremely helpful. Team-based learning and simulated patient activity I'm going to describe counts for 10% of their block grade. So we wanted them to take it seriously. If you tell a medical student that this is worth 1 or 2% of their grade, they'll take it seriously. But 10% is real serious. Now they have to get really serious about preparing for this. Is pretty much everybody familiar with team-based learning? Okay, you guys probably use it. I'm going to just briefly explain it for those of you that aren't used to using it. Team-based learning is an evidence-based educational modality which employs what's called the flipped classroom. So there are these different phases. In phase 1, the educator creates learning objectives of what do you want the student to be able to do at the end of this exercise, and then they tie specific readings, typically not too much reading or they won't do it or they'll complain, but you tie specific readings to those learning objectives. The student prepares this in advance of the intervention. In phase 2, they have what's called readiness assurance. So the first part of that is the student comes in and they take a multiple choice test, which is called the Individual Readiness Assurance Test, or IRAT. So I might use this. So this is just a multiple choice test they take by themselves. It counts for a percentage of the grade for the module. As soon as that's done, the students turn that test in, and then they take this exact same test, but in a group. Now they're in groups, and they're discussing, and they're talking about the answers, and this is where a lot of the learning of team-based learning takes in. The faculty member simply facilitates those discussions if needed, and at the end of a certain amount of time or process, the students are allowed to ask questions to the facilitator about questions they have. Now, if you guys know medical students, which you do, this is not supposed to be nitpicking, like, I didn't like answer choice F. Okay, there's an appeals process for that if they don't like the wording of a particular question. This is, I genuinely did not know why we have to talk about, what the difference between a do not resuscitate order is and a living will is. And then the facilitator can help by asking another group, well, did anybody get this question right? And then having the other group answer and so forth. So this is the group readiness assurance test, and that's phase 2, and then you have some instructor feedback. And in phase 3, this is the application exercise, and this can take a variety of different forms. So team-based learning has been used inside of medicine, outside of medicine, in nursing. It's been used in dental school. It's been used in a lot of different disciplines. It's been used in anatomy. And a lot of times, with the application exercise, okay, so it's now the student has pre-prepared, the student has demonstrated that they're ready. Now let's have them show what they know in the application exercise. And the form of the application exercise can take a variety of different forms. It can be a paper case that students have to work through. A lot of times in things like anatomy or biochemistry, they will use team-based learning, and the answers to those questions in the application exercise might have a clinical vignette with a definite objective answer. Okay, if you're doing pharmacology, there probably is a right answer. And the challenge in teaching ethics or communication skills, etc., is that if there is a right answer, you might not get to it, right? So that involves some adaptation. But this phase, the group application exercise, can take a variety of different forms, and you're not held to a particular form. It's just, can you get the student to apply what they've learned so that they see that their preparation was relevant to acting out or practicing a skill that you want them to be able to do. Now, one of the other modalities that's often used in medical school, you guys have a sim center here with patient actors. Okay, so you guys are used to this. And you know that OSCEs and the use of simulated patients, here they are standing outside the door. Before they go into the room, there's a patient actor. And there's usually a faculty observer who then grades, right? Objective, structured, clinical examinations. Okay, so SPs have been used within OSCE, so simulated patients have been used within OSCEs. That's been demonstrated in the literature. This helps to improve learning. But as you know, the problem with OSCEs is expense, okay? It costs money to train actors, logistics, and then faculty resources. You have to have an observer who is trained, who gets faculty development and is trained. So even though a lot of times they sort of talk about OSCEs as a really good modality, and it is if you can afford it, and it is if you have the faculty and staff, the logistical resources to be able to do it. So if we look at this sort of schematic comparison here, traditional team-based learning in med school involves this kind of know-how approach. We're not just testing you with a multiple choice question about knowing something. That's what the IRAT does. But the rest of the team-based learning module can show that you know how to do something by doing something analytical in your application exercise. Within the team-based learning exercise, you get immediate feedback, right? Because you have a faculty facilitator who can talk and kind of move the students along toward the learning objectives and can give them immediate feedback. It's really faculty non-intensive. I have run team-based learning exercises with 200 people, 200 students at a single time. I've done it with 100, I've done it with 110, 150. So it's really faculty non-intensive. You only need one faculty facilitator, and they don't even have to be a content expert necessarily. They just have to be a good facilitator, because the students, in theory, would have mastered the content. And of course, low cost in hours and in training and in faculty development. Now, with traditional OSCEs, you do have this benefit. You've got the know-how assessment, but you've also got this show-how assessment. So you can actually observe someone who's demonstrating a skill, and that is a lot harder to do with traditional team-based learning exercises. Okay? So being able to show how is important. You still also get this immediate feedback. Sometimes you can get formative feedback from the simulated patient right there in the room, and you certainly get summative feedback from whoever is observing in the OSCE. Now, this is important. The show-how assessment we felt was still important because we're trying to teach them communication skills. We're trying to teach them ethics. It's hard to do that if they have a paper case, or if the people in the room doing the application exercises are the same people who are talking all the time. So we wanted to develop an exercise that integrated SPs and team-based learning into a group application exercise that would help us to alleviate some of the shortcomings of both. Now, if you guys are Lord of the Rings fans, you remember this. This is Gandalf's appearance in Fangorn Forest. But essentially, I'm going to tell you another story, which some of you may be familiar with as medical educators, which is essentially that, yes, we wanted to do this. This was our quote-unquote hypothesis, but we were also commanded to do this in a way, right? So the people in a higher pay grade than me basically said, you're the director of this course, and we need, the LCME is coming sometime, and we need to show that we teach and assess end-of-life decision-making, shared decision-making, ethics, advanced communication skills, health literacy, and what was the other one? Oh, and delivering bad news. Okay. Now, you can do this, and so there was suggestion, well, we have to show that you teach it and you assess it all, and that every student has essentially the same experience. There you go. And the suggestion was, well, you can just do a multiple choice question test, which I abhor, and I didn't want to do that. I mean, I could have just given them readings and then test them and then show that we're teaching by having them read and then assessing by doing a multiple choice question. But that wasn't good enough, so I decided, well, let's try this combining an SP and team-based learning, okay? So we created a team-based learning exercise using the standard evidence-based methods you find in papers like Michelson and Sweet. So the learning objectives were created. We created an IRAT, and this was worth 30%. Now remember, this is the multiple choice question test that they take on their own. And then there was a GRAT, which was 15 minutes. And you can see from this distribution of the grade, 30% and 60%, we're weighting the group activity a lot heavier. This helps the student to not get angry about the TBL, because as soon as a med student gets mad, they just shut down. It's like it's so ridiculous. But even I have to give them a warning. Like, if you guys miss a question, don't shut down for the next hour and a half and pout and not learn anything, because these are important subjects that you need to learn. So we weight the group part very heavily so that they end up with a pretty good grade and they can feel more relaxed about actually participating. Now, what we do is any student that is on the rotation, so it's a 2-block rotation, okay? So any student that happens to be on their rotation can sign up to take the team-based learning exercise. And so we've had cohorts of about 6 up to 36 students taking this at once. Now, they're in groups of 5 to 6. And this is an example. This is an IRAT. This is like one of the questions that we asked them. And here you can see kind of our distribution. If you can read that, end-of-life care. We have 5 questions that we can utilize from our question bank, and so on, some of the questions we asked them about. But essentially, this is just a multiple choice question. And then this is for the GRAT, you guys are probably familiar with this, but I just wanted to show a picture in case you weren't. When they take this is called an IFAT card or an IFAT card. And this card is how they take this test as a group. So they talk about the question, they talk about an answer, and then they scratch off whichever the group comes to a consensus, not a multiple choice thing, but whatever they think is the right answer, and then there's a little star. And because med students and other competitive people take these tests, you'll notice on the IFAT cards they move the star around underneath the silver because people try to scratch a little bit off and see if it's there. So you never know where that star is going to be. But that's what the IFAT card looks like. Now, the TBL, like I told you guys, this TBL SP is worth 10% of their overall grade. And so they've done the IRAT, they've done the GRAT, and now we get into the application exercise. So I'm going to actually give you guys a copy. This is the actual application exercise we use so that you can follow. This will make more sense as you look, as I'm talking. If you look through this, 1, 2, 3, 4. Go. There's one for you. Do you want one? Okay. So this is actually the case that we give them as part of the application exercise. So you have an SP that's interviewed, and I'll explain what's on the page in a second. But this just gives you an overall view. So we have, remember, 6 to 36 groups. So we have a group of 6, a group of 6, a group of 6. We have a simulated patient or an actor that is interviewed within a small group, and students take turns interviewing the patient. The SP then gives formative feedback to the student at the end of the exercise. There's a faculty facilitator that's also watching this small group of 6, and that faculty facilitator will give summative feedback to the student at the end, right at the end of the exercise, and also during the exercise will give the students a cue to switch so they know which student, or whichever student comes next. There's also a peer who's assigned to observe another peer during this exercise, and they give their peer a grade. And so the summative feedback is the average of the faculty observation and the student observation, and that determines their 10%. So now you guys can look at the case, and you can look at that first sheet. This is a patient. The case we give them is a patient who's about to learn that he has ALS, or Lou Gehrig's disease, which is a fatal diagnosis. And after we let the students read the case, they're given a fact sheet on ALS, because these are fourth years, and ALS is a complicated disease, so I realize that they're probably not all going to remember everything there is to know about ALS. So this is an example of what the classroom setup might look like. The person taking the picture is me, so I'm like sitting there watching the point of view of the faculty advisor. You have a little group here of medical students who are observing the encounter. Here's the medical student, and here is the actor. And the actor is called into the room, and whoever is, so this is the case that you guys have in front of you. So students were assigned, so you know you have this group of 6. Students are assigned a speaking order at the beginning of the exercise and a peer that they're supposed to review. Now, how did we do this? Very primitively. So I actually have these, I mean, it's like literally like index cards, right? So I can show you that what students will pick a random card. This first number, the big number, is their assigned speaking order. The small number is the speaker that they have to peer review. Okay, so they all have their speaking order, and they all have a speaker that they have to review. Does everybody get that so far? Okay. So then a trained simulated patient, and we train our simulated patients really about an hour. They've already gone, like probably for your sim center, you probably have like a cadre of actors who already goes through a lot of staff development as far as how to be an actor and how to act out these scenarios. So they're used to it. We gave them like maybe an extra 45 minutes or an hour to review this case, and we train them all to do this. And then, so there are sort of 6 objectives: delivering bad news, health literacy or medical facts, lifestyle changes, prognosis, treatment, cure or lack of, end-of-life choices and planning, and then the last part is a physician-assisted suicide request. Now, they don't know ahead of time about any of this. So they're supposed to go into the encounter, speaker 1 goes into the encounter as if they're going to do the entire interview. Now, if you look at the script I gave you, so this would be on page 3 of this script. It's easier if you kind of walk through it. But on page 3 of the script, so you have student number 1. Let's see. So student number 1 is the person who has to pretend like, hi, I'm Dr. Fernandes, or they pretend that whoever they are, and goes through and is in charge of delivering bad news. So on the left, in the left-hand column, is for the faculty. That's a description of what the faculty should be looking for, and also what the specific learning objective for that particular student, whoever happens to draw card number 1 is. They're supposed to deliver bad news according to the way we've taught them, the spikes, mnemonic, or whatever reading they might have. And then you can look on the right, these are instructions for the SP. So in the right-hand column, the SP has a little script that they can modify or choose to use. But then at some point, you see it says, Q for student 2. So at some point, the student will start to break the bad news, and then this SP will say, okay, wait, that's too much. Can you just first explain what this is medically? Now, the faculty member has this script that you guys are holding in your hand. So as soon as they hear the SP say that, they say, next student. And then student number 1 is replaced with student number 2, who then has to go through and explain the medical facts using the principles of health literacy. They've already had a pre-reading on this. So they should be able to know how to use simple, plain language to explain a complex disease. So if they say something like, Lou Gehrig's disease is a neurological degradation of synapses in the blood, the faculty member knows, well, hey, that's not utilizing principles of health literacy, and they can use that to assess the student about whether they used principles of health literacy, and so on. And so it goes. The SP is trained to know when to cue, and the faculty member has this script so they can keep advancing to describing the health styles, the lifestyle limitations with empathy, prognosis and treatment options. So here we give them description of what palliative care versus hospice care is. They're supposed to explain, hey, this is an incurable, so that if you go to number 4 here, student number 4, which is on page 4, it actually says, she's like, I don't like what I'm hearing. What are my options to beat this? this is the Ohio State University, right? You must have some kind of treatment plan or whatever. So then the student has to explain there is no treatment, has to explain what the prognosis is, and might have to explain, yeah, there's no treatment, but can you explain what palliative care actually is to a patient who asks about it? And then it keeps going, so then there's end-of-life options. And then finally, and if you look at this next, let's see if I can, so this is the script that you guys have in front of you. If you look at number 6, student number 6, this is the person that draws the short straw. Like, they have no idea this is coming. A patient, simulated patient will say, I have one last question. Okay, so then you switch, and the 6th student comes up, and then asks for a prescription for Percocet, and asks the doctor, hey, can you just tell me how many I need to take to end this, because I want control over the timing and manner of my death. Okay. Now, sometimes they're a little bit more subtle than that, depending on how the SP takes it. Some of them will cry. Some of them will get mad. Some of them will be like, Now, however the student answers, which typically in Ohio, since it's illegal, the first thing the student typically will say is, well, it's illegal. But the SP is trained that no matter what answer they say, to push back on the student. Okay? If they say, because of the law, they can say, well, nobody's going to even know. You can just say it's for pain. I'll do it myself. If they say it's an ethical and moral reason that they can't do it, like they're personally opposed to it, then the SP is trained to say, hey, it's my life. You can't tell me essentially, you can't tell me what to do. You need to give me control. And if they still hold their ground, then there's a question about referrals. Okay, well, you don't want to do it, that's fine, I get it, but you should just send me to someone who can do it. And then we have the student try to answer that. And then the last thing is, if they agree to it, then we say, well, all this stuff about palliative care. So basically, the student is kind of screwed. Okay? But it's very realistic. That is, the discomfort over the ethical ambiguity of this. The simulated patients are very good. I mean, some of them will cry. Some of them will get very angry. So the student is really put in a challenging, and this is just a joke about the Department of Justice, like if they agree to it. But essentially, no matter what the student says, we want them to understand that you're going to get these kinds of ethical, and the faculty are trained not to judge the student or assess the student on what their answer is. So we have faculty that are opposed to assisted suicide. We have faculty that are in favor of assisted suicide. It makes no difference. What you're looking for is whether or not the student handles himself well, doesn't get angry, shows patience with the patient, and ultimately how the successful student in Speaker 6 is the one who offers presence, the presence of themselves, offers for follow-up, or says something like, you know what, I understand. Why don't we see each other? Why don't we think about this, and you can come and see me again. That's more of an appropriate response than, and we point out that even if you believed in assisted suicide and were willing to do this, the statutes that govern assisted suicide in the states like Oregon and Washington still require 2 physician requests, 15 days apart. You probably shouldn't be doing this on a first visit. And if the patient is really emotional or whatever, you probably should wait it out anyway. But it's an interesting, so this is how we kind of bring in the ethical piece into it. Students love this part. And the other students, the 5 others that are watching number 6 go, are, first of all, grateful that it wasn't them. And then, but secondly, and this is true with this entire scenario of the mix of allowing a group to interview the patient, is they are watching their colleagues who are soon-to-be doctors exhibit different communication styles. They're learning, how would I handle that? How would I not handle that? And so this last part is the feedback stage. So when the scenario ends, we say, okay, the scenario's over, and we say, who is speaker 1? And let's say it's this guy. We have the SP give him, and then I reveal what your job was. So your job was to deliver bad news, following the principles that we learned about delivering bad news. How do you think he did? And then she will give him some formative feedback. And then I say, okay, well, who was supposed to evaluate speaker number 1? And that student, let's say it's this guy, he'll give him feedback. And then if there's anything left to be said, the faculty member in the room who's observing will also give feedback. Now, because, remember, we had this people higher than me who said, well, every student has to have the exact same experience and has to know how to do every single thing. Our reasoning was, because the speaking parts were chosen at random, the students had to be prepared to fill any part. And because they also had to peer evaluate another medical student, they also had to know that part as well. So they really kind of had to be prepared for all parts in order to do well in this scenario. So they don't have to, we felt like this was one way, in a way it's an advantage over an OSCE, because you don't have to have a faculty member for every single student, and you don't have the logistical nightmare of it having to take an entire day. So this is an example. We created a very, very simple peer evaluation form that's basically a grade 3, 2, or 1. And we set, 3 fairly high, perfect or near perfect execution in terms of content and humanism or empathy. So it wasn't just enough to get the kind of right words down. You also had to show, or at least demonstrate, that you actually cared. Obviously students are going to rate each other almost always 3s, which is a common problem with peer evaluation, but sometimes they're fair, and then they write comments down here. And we look at their peer evaluations to see if they actually put in effort in writing down comments, etc. So this is a kind of a summary recap. But if you look at this, the difference between a traditional team-based learning exercise and our hybrid, they both have pre-reading, they both have an IRAT, they both have a GRAT. But this feedback is really enhanced in our model because you're getting immediate formative feedback from the SP, and then you're getting feedback from a peer, and then you're getting feedback from the faculty, and you're witnessing other students and how they communicate. And then the other part that's different that we think is better is that simulated patients are interviewed in sort of real time, and the learning objectives are discovered throughout, okay? And then, and we talked about this, you get observed demonstration of other things like diagnostic, communicative, and humanistic and ethical skills. So, whoops, I don't know what happened there. Oh, it didn't show up, did it? Okay, well, I can tell you. That was weird. It worked a second ago. But I can tell you, and I'm going to give you guys at the end of this I can tell you that when we did we did a Likert scale to evaluate whether or not the students, what they thought of the exercise since it was relatively new. And 80%, so the Likert scale was a 5-point scale, and 5 was strongly agree, and 4 was agree. And 80% of the students agreed or strongly agreed with each of the 7 quantitative items that we had. And of particular interest to us was that 89.4% of students agreed or strongly agreed that the integrated SP exercise was an effective way to both learn and practice the skills needed for delivering bad news, demonstrating shared decision-making, and discussing end-of-life care in a humane and ethical way. Central to that was the novel use of the SP within the exercise. Now, why that didn't show up, I don't know. Then we asked them qualitative questions about what they thought was good about the exercise and what they thought needed improvement. And so we divided those. When we looked at those and we did a thematic analysis, we found 4 basic themes. One was the effective experience or practicing skills. And here we sampled a couple of medical students. One says the interaction with the standardized patient, while seeming artificial at first, really illustrated the difficulty in delivering a terminal diagnosis even in a standardized setting. And then another student said, the interaction with the standardized patient was great going into the TBL. This was not what I expected, but it was really great to practice to deliver bad news in a terminal illness in a safe and constructive environment. Increased engagement was the other one. The use of patient interviewing with an SP for the application exercise was a nice twist and helped to apply the key principles in a more practical setting. And then I liked that interaction with the SP and the associated feedback. This is a hard topic, and the only way to get better is to practice. And this is something students often don't get to do. You could go through your medical school career and not actually get to do some of the things you're able to do. Now, people liked the inclusion of SPs within the traditional format. And then enhanced positive opportunities for feedback and discussion. Oh, before you leave, sir. before you leave, I wanted to give you this. This is actually, we just published this paper. No, that's okay. We just published this paper, so I wanted to give all of you a copy of it, and then you can read the results and have an actual table that actually works, that shows the results. The top 5 negatives, when we asked people, well, a lot of people said nothing. There's no negatives. These being medical students, about 1 in 5 hated the wording, and then if you look at this one, ethics is too subjective to be graded. They didn't like ethical questions at all. And then some of them were really kind of really fair critiques. The disjointed nature of the interviewing, saying next student, some of them found that contrived. We found one way to deal with that is to just tell them up front, this is a deliberately contrived exercise. Normally you'd be doing the entire thing on your own, but just being upfront about that, and then kind of allaying some of this anxiety. And because they do well, ultimately they're happy at the end, because they all know that they've done well. So we've kind of gone through some of this already, but some of the advantages: it allows students to practice and receive real-time feedback. It covers complex topics you may not cover in medical school. This is one that I've realized since I've been at Ohio State. Students are really OSCE'd to death, and they hate it. By the time they're in 4th year, they just hate OSCEs. And then they've got step 2 CS that they're all worried about, and that's another thing that they get an OSCE for. So this allows them a little slightly different approach to the OSCE. Our plan, we want to be able to expand this and do other scenarios integrating simulated patients. We hope other people will try it out. And one of the things, so next year, in this coming academic year, we're creating one that deals with an opioid-addicted person. So it's going to follow a very similar format, but it's going to have a hard conversation about a drug-seeking patient, where the student will have to interact in the same way, and of course there'll be an ethical question that's integrated into it, but getting them to have that experience of how do you have these hard conversations is important, and we think one of the only good ways to learn. That's all I have. Thank you very much for your attention. I'm happy to take questions. And I can pass these out to you guys.
Oh, sure.
Anybody have any questions? Yeah.
How did you, so in a group setting, if you had, is randomly assigned what role they were going to play, for example, or what portion of it, how did you handle students who struggle with the role? Because, in most ASCII, they do it themselves, right? The whole thing.
Right.
You have strengths and you have challenges.
Right.
And you capitalize on your strengths.
Right.
Like in practice, right?
Yes.
You tend to gloss over the stuff you don't do as well. I imagine this would bring that to the forefront, right, a little bit.
Yes.
How did you handle that?
So do you mean during the exercise, or if someone did really...
This is so in terms of assessment,
right.
As an application exercise, obviously it's probably a little more formative than this is in any way summative. But
right.
If you had a learner who really just couldn't do their portion of it, how did you address that?
Okay, so first of all, lucky for us, we've actually never had a person that could not perform their portion, and I think that probably speaks to the fact. I think it speaks to the fact that the team-based learning, by the time they get to where they are in 4th year, they're really used to team-based learning exercises. They understand, hey, this is 10% of my grade. They come in prepared, and we feel like that's a good sign that they have anyone. Now, the one place that people do struggle with is the ethical question at the end. And we never, the faculty are trained, the other faculty who help us with this. And again, we've only had 6 small groups at a time, because these are students that are rotating through. So we've trained about myself and 5 other faculty to be able to do this exercise. We have trained them to never intervene when a student is struggling with it, and to just let it go. Eventually, they will get it between trying to figure... the 6th one, they have a hard time with, or sometimes the SP will guide them in the correct direction. If they do poorly, then what typically we'll do is, we talk about that 6th question a lot. That's where most of the discussion happens. And so we kind of tell them strengths and weaknesses. Now, it is in front of everybody. But we also ask, well, how could, you struggled, what did you think was was going on. So we asked them to kind of point it out themselves, and then their other colleagues, their 5 other colleagues, also help. They're like, yeah, that was really tough. I might have tried this. What do you think of this? So we have a discussion. Now, we don't reassess them. I guess if they really bombed it, they would probably get a 1 on the peer evaluation, but most likely the student evaluator would probably give them a 2 or a 3 anyway. And so when it averages out, they end up, and that's only worth 10% of their grade for the team-based learning exercise. So in truth, I mean, it would be great if we had the time in the 4th year where if students didn't do well, they could come back, but we don't have anything like that. It just hasn't.
Do you let them jump in during the exercise?
No.
Or the instructor is strictly, if it's portion 2 and you're number 6, do not talk?
Yes. And in fact, at first they're very nervous. When you explain this exercise to them, they're like, we do what? And then how do we know that we've hit the learning objective? Or how do we know? And I'm like, we have had hundreds of students go through this exercise now. No one has ever been still sitting here. Like, you get it eventually. And some of them get it really surprisingly very early and are prepared for it. In fact, every once in a while, we have this discussion about whether the word about this team-based learning SP exercise is getting out to students and they're passing it down. Because some of them are so good that I'm like, that's really good. And I'm wondering if you heard about it and know that you have to do this. Part of our impetus for doing the opioid case for next year is to kind of mix it up and to sort of test the same skills, but do it with a different scenario. It's probably a good idea anyway, just to refresh it. But yes?
Yes, so we do this with our M3s with communicating difficult news and palliative care. I was wondering if you had any success in doing TBL with more of bioethical issues, more fundamental ones like information disclosure.
Oh, yeah.
And various types of philosophical concepts.
Yeah, so that's a great question. So now I have not done using a simulated, we've done role play as part of the application exercise. So let me back up. One of my other roles is I'm the director of the ethics curriculum for the pediatric residents at Nationwide Children's Hospital, which is one of the largest children's hospitals in the country, and one of the largest residency programs. And we've developed a completely, an all team-based learning ethics curriculum. So we test them on 10, now we have up to 12 different purely, now they're pediatric bioethics, they could easily be adapted, but pediatric bioethics subjects starting with, in fact I'm doing one tomorrow on an introduction to pediatric ethics. But we give them, again, pre-reading with some of the basics, and then we do IRAT and GRAT, and then they have a group application exercise, and that takes a variety of different forms.
What are some of your topics?
So in pediatric ethics, we do like assent and consent, research ethics, child maltreatment and child maltreatment and family violence. We do confidentiality. We just did one on migrant health, which was really, actually that was an interprofessional team-based learning exercise where social work professionals were integrated into the groups, into the group application exercises with pediatric residents. And they worked on a common problem. I mean, that's the key thing for the application exercises. The students have to work on a common problem. They have to come to a consensus. So in fact, I have a whole list. I can actually.
Are these for residents?
Yeah. So these are the ones we created were for residents, but they could easily be adapted to really almost any setting. In fact, we just got a grant from the Gold Foundation to expand this curriculum and to disseminate it to other institutions. And so, I'd be happy to talk to you offline about that, but that's one of the things that we hope to be able to do. I think team-based learning, I'm a big believer in it, because I think for ethics, what it does is there are some objective things, these sort of fundamental principles. Like you have to know in pediatrics, for example, which is my discipline, you kind of have to know what the difference between a mature minor is and an emancipated minor, or what are the exceptions to confidentiality, or what are some of the things that you have to keep confidential in a teen patient. Those are some objective findings. But so you can test them on that, and they're tested on the boards. And so, in fact, how we market it to the residents is This is board prep. It's clinical prep, like it's preparation for your clinical life, but the IRAT and GRAT, we put them in board-style format so that they understand this is what you're going to get on the exam, and it makes it relevant to them. And then there's some other adaptations, like we have to decrease the number of readings. That's a challenge because residents have no impetus to read, right? That you don't grade them. They're not going to get, if they read nothing, they don't care, a lot of them. So we have to adapt the TBL process a little bit. But again, the application exercise needs a lot of creativity. And in ethics and some of these other difficult subjects where there's ambiguity involved, where there's, I mean, there might be correct answers, but it involves a process of reasoning. It really lends itself to a to sort of a safe zone. I hate to use that term, but kind of a safe zone where you can talk about ethical issues without students fearing that they're going to be somehow retaliated against. The way I run it is, as someone who's a philosopher, is I say, you're allowed to talk about anything. Like, I don't shut anything down and say, well, no, that's wrong. You're not allowed to do that, because the whole point of TBL is to facilitate. If you're the leader, you're just facilitating a discussion between different opinions in the group. Now, if someone said something that was really factually wrong, that would be something different. Yes?
Do you address the question of remediation in your work on teaching ethics?
So you mean in teaching ethics, or this particular?
Generally, in different arenas that you...
Yeah, so we do have, one of the other things I was prepared to talk about, because I thought I was going to do 2 talks here, but was professionalism remediation, which is kind of all over the map at most medical schools. I'm kind of developing a more personalized approach to that. As far as ethics remediation specifically goes, you really remediate specific exercises that you fail, either through, and it's typically by doing a re-examination. Now, with team-based learning exercises, what we typically will do is if they fail the IRAT part, because it's very difficult. Let me back up and be really frank. It's very difficult for a student to fail the entire TBL exercise in ethics because of the way that we've weighted the different parts. You could fairly easily fail the IRAT part if you didn't prepare and you just walked in and decided you were going to take it. But because the group exercises, and this is true in all the evidence about team-based learning exercises, the group grade always pulls the student up. And then the application exercise, because it's very low pressure, and it's really more of a discussion or facilitated discussion, students will typically do quite well on that part too. So we rarely have any, now, ethics, so on the ethics content, there's really rarely a need for it, and we would just retest them. If you're talking about ethics as far as like their ethical behavior, we have some remediation processes in place for that. And those usually go through professionalism committees. And then the thing that I do, which is like a more personalized approach to professionalism remediation.
In terms of your professionalism committee, how would you handle it, for example? Let's take a scenario like this.
You mean a student with a bad behavior?
Yeah, just broadly speaking.
Yeah, so if a student has an unprofessional or unethical behavior at my institution, I mean, honestly, I just became the director of the professionalism competency in July. And there's things I want to change, but, Ohio State is a relatively concretized institution. I think it needs to be more streamlined. I'll tell you what we have now. We have these various committees. So we have an honors and professionalism committee, which is composed half of students and half of faculty members. And so sometimes people are referred there, and they're kind of known as like being very light, like slap on the wrist, oh, you shouldn't have done that, and quite sympathetic to the student. And then we have something called student review, which is a little higher level of a committee that says, hey, what went wrong here? What do you think you should do? Here's our suggested plan for your professionalism remediation. And then we have a third committee, which I'm a part of that committee, which is called Academic and Behavioral Review Committee. And if you go before that and you're in serious trouble, like they could kick you out, they could recommend you take time off, get mental health, your mental health issues sorted out, or that this is an egregious violation, they could recommend up to dismissal. So you sort of have those 3 levels of committee, generally speaking. But it's kind of not really adequate, because if you fail USMLE or if you fail a medical knowledge exam, there's a remediation process that's in place and it's objective. And you could say, okay, well, you have to retake. You have 2 weeks to retake the exam. Here it is. Here's the exam. Okay, you remediate it. Okay, now you know cardiology. But if you fail professionalism or ethics or have an unprofessional or unethical behavior, you can't really, it's very challenging to develop a system where you can look at the student's behavior later and say, okay, well, now you know professionalism. You're done. In fact, one thing that prompted me to do something different was there was a student who had some unprofessional behavior. They were required by the student review committee to meet with an internal medicine doc for 1 hour. And that doctor said, what do you think professionalism is? What's the definition of professionalism? So this student recited some thing. They had a conversation for a little less than an hour, and then he wrote a letter saying she remediated her professionalism. And of course, what happened? Then she appeared before ABRC, before the highest committee again, after a second professionalism violation. They were like, well, you already had professionalism remediation, which you failed, which you supposedly passed, and now this is your second thing. And I looked at that and I said, you know what, that's not really that fair, because the remediation for that wasn't good. It was bad. And it didn't demonstrate that she had actually remediated it. And so, and I know we're out of time, but I can talk about this too, but basically what I developed is an approach that's individualized to the student. It's longitudinal. It's reflective. You have to answer six handwritten questions and then meet with a professionalism kind of faculty coach who's typically an MD. Do some clinical hours with that person, and do this over a period of time, so that the faculty member gets to know the student and can actually hold them accountable for their behavior. And I think my experience with an N of now 7 is that this has been effective and can actually work, and it shows like a seriousness. Like, we're not just trying to teach you a definition of professionalism, we're trying to mold your behavior. But all of that takes time. This is something where it's going to take time, it's going to cost in terms of faculty involvement, and you're going to have to train people who are dedicated to that cause to help. Luckily for us, we might have 2 or 3 of these students a year. So, thank you.
So, thank you so much, those that have been joining us for lunch. Brianna's lunch.